Well, welcome to part one of our series on hypoglycemia, where we break down the science behind low blood sugar and why it matters. So, let's walk through the key points for understanding hypoglycemia. First, we'll start with the definition and threshold, and according to the American Diabetes Association, hypoglycemia is defined as a blood glucose level below 70 milligrams per deciliter. Next, we'll look at why it matters. It's all about brain dependence on glucose as the primary source of energy. Then we go over the classification of hypoglycemia. We divide it into mild, moderate, and severe hypoglycemia. Finally, we'll cover common triggers of hypoglycemia in diabetes care. So hypoglycemia can show up in many ways, but sometimes alone aren't enough for diagnosis. To confirm true hypoglycemia, we use the Whipple's triad, a clinical rule introduced way back in 1938 by Surgeon Alan Whipple. It requires three things. 1. Symptoms that suggest low blood glucose. 2. A measure of low plasma glucose level, and symptoms that improve after giving glucose. Now, this triad help us separate real hypoglycemia from look-alike condition where symptoms may be present but glucose level are actually normal. So why hypoglycemia matters? Well, it's all about the brain. The brain depends almost entirely on glucose as the primary fuel. Unlike muscles or the liver, it cannot store glucose or switch easily on other energy sources. That means even brief drops in blood sugar can impair brain function, leading to symptoms like confusion, dizziness, blurred vision, or even seizures. This vulnerability makes hypoglycemia especially dangerous. It is not just about feeling weak or shaky, it's about protecting the brain from energy failure. That's why early recognition, prompt treatment, and prevention are critical in diabetes care. Okay, so while Whipple's trial helped confirm true hypoglycemia by linking symptoms, glucose levels, and response to treatment, it doesn't tell us how to categorize different types of hypoglycemic episodes in clinical practice. That's where the ADA and the Endocrine Society classification comes in. It builds on Whipple's diagnostic foundation and offers a structured way to describe hypoglycemia based on severity, symptoms presence, and glucose availability, ranging from severe events requiring help to asymptomatic or even pseudo-hypoglycemia. Together, these tools guide both diagnosis and day-to-day management. So symptoms alone, again, are not enough to diagnose hypoglycemia, while shakiness, confusion, or sweating may suggest low blood sugar. True hypoglycemia must be confirmed using Whipple's triad. This again includes three key criteria: symptoms consistent with hypoglycemia, a documented low plasma glucose level, and resolution of symptoms after glucose corrections. This approach helps distinguish real hypoglycemia from other conditions that mimic it. Whipple's trial, introduced again by Dr. Alan O. Whipple in 1938, remains the gold standard for confirming true hypoglycemia. As shown in the diagram, glucose measurement sits at the middle, at the core, connecting what the patients feel to what we can measure and treat. Now, the American Diabetes Association now define hypoglycemia not just by context but by severity based on glucose threshold and clinical impact. This updated system includes three levels. Level 1, hypoglycemia, is a glucose concentration between 54 and 69 milligrams per deciliter, or 3.0 to 3.8 millimoles per liter. Now, it serves as an early warning, prompting awareness and action before symptoms escalate. Level 2, hypoglycemia, is defined as a glucose level below 54 milligrams per deciliter or under 3 millimoles per liter, and this is the threshold where neuroglycopenic symptoms like confusion, blurred vision, or impaired judgment typically begin. And lastly, level 3 hypoglycemia is the most severe. It's not defined by a specific glucose number, but by the need for external help. The person experiences altered mental and physical functioning and cannot recover without assistance. This tiered approach helps clinicians prioritize intervention, tailored education, and protect patients from both immediate danger and long-term complications. Again, hypoglycemia classification in a table form: mild, moderate, severe. Hypoglycemia is classified by severity to guide treatment. Mild, again, glucose 54 to 69 milligrams per deciliter. Early symptoms like shakiness or hunger, person can self-treat. Moderate, glucose level less than 54 milligrams per deciliter. Symptoms like confusion or blurred vision. Self-treatment is still possible but more difficult. In severe cases, again, maybe less than 50 milligrams per deciliter or unmeasured. Person has impaired function and needs help from others to recover. These categories align with the ADS level 1, 2, and 3, helping clinician respond appropriately based on the risk and urgency. In a 2017 joint statement published in Diabetes Care, the American Diabetes Association and the European Association for Study of Diabetes recommended that the clinical trial report any glucose reading below 3.0 millimoles per liter or equivalent to 54 milligrams per deciliter. Now, the reason for this is because in clinical trial, reporting glucose level below 3 or 54 milligrams per deciliter allows the diabetes and regulatory communities to compare how well different intervention, whether pharmacological, technological, or educational, reduce hypoglycemia. It also enables the use of meta-analysis to strengthen statistical comparison across studies. So in diabetes care, recognizing common triggers is essential for preventing both hypoglycemia as well as hyperglycemia. This diagram highlights 6 key categories. At the center is the glucose meter, a reminder that all these triggers influence blood sugar control. First, dietary triggers include missed meals or high glycemic food that cause erratic glucose swings. Next, medication-related triggers involve missed doses, incorrect timing, or drug interaction that disrupt insulin or oral therapy. Illness and fever raises stress hormone, increasing insulin resistance and glucose levels. Stress also, whether emotional or psychological, can elevate blood sugar and reduce adherence to care routines. Physical activity, especially unplanned exercise or prolonged inactivity, can cause unpredictable glucose changes. Finally, routine disruptions such as alcohol intake, travel, or sleep changes interfere with meal timing, medication schedules, and glucose rhythms. By identifying and addressing these triggers, we can personalize care, improve safety, and empower patients to manage their diabetes more effectively. So to sum up what we've discussed, we talk about what hypoglycemia is and how it is defined. We explain why the brain depends on glucose to function well. We look at how to tell if an episode of hypoglycemia is mild, moderate, to severe. We identified common causes of low blood sugar in everyday diabetes care. We introduced Whipple's triad as a way to confirm true hypoglycemia, and we emphasized the importance of checking glucose level for safe and effective treatment. Up next, we'll focus on recognizing symptoms and taking action in part 2 of this series. Thank you so much for listening.